So great. Now we will request Dr. Madan Mohan sir to introduce the next speaker. Thank you.
Now I would like to invite Dr. P.R. Srijithesh. He will deliver on the acute stroke revascularization, principles of patient selection and deviation in practice. And chairperson, I would invite Dr. Neeraj Bhutani sir and Dr. Gaurav Goyal sir. Please, chairperson. Dr. Neeraj Bhutani sir is a senior consultant in Department of Neurology, Atulabh Memorial Hospital, Jaipur. And Dr. Gaurav Goyal sir is a consultant neurologist, associate professor in Mahatma Gandhi Medical College and Hospital, Jaipur. Thank you, sir. Dr. Neeraj Bhutani sir. Dr. Surendra Khoshia will welcome Dr. Surendra. Thank you, sir. Dr. Gaurav Goyal sir. Dr. Surendra Khoshia, welcome Dr. Gaurav Goyal sir. Dr. Surendra Khoshia will welcome Dr. P. Srijithesh sir.
Good morning, everyone. Today's opening batsman for today's academic innings is Dr. P.R. Srijithesh. He's an additional professor, Department of Neurology in Hemorrhage, and he's a member of prestigious airway group Cochrane collaboration. He has a special interest in stroke, and he has been a principal investigator of many ICMR extramural projects. He's especially interested in stroke care pathways, sleep disorders in stroke, and medical epidemiology. And he will be talking on patient selection for revascularization in acute stroke, which is a very, very important topic because the selection is the most important factor which determines the outcome. So I welcome Dr. Srijithesh, please.
Morning, all. At the outset, I should thank Gupta and for inviting me. Indeed, a pleasure and honor to speak before my teachers and mentors. So, I'll be talking on revascularization, principles of theory and practice. Here, I will start with a case that the deviations in practice are essentially constrained by our work environment. It cannot be applied universally across different scenarios. I had discussed with many of my colleagues out here, Tarachand and all, how stroke is practiced here, and especially in a private setup. So most of the deviations which I discuss here cannot be applied. Essentially, these are derived in the work setting which we work. So I just want to have an idea, like of this audience, how many are physicians, how many neurologists? Because I just want to physician, neurologist. So, like in your private practice, like how many of what is the main modality of intervention? So, acute stroke patient come in window, therapeutic window. What would the main modality? What is the preferred modality for physicians? For the neurologist in practice, main modality is it MRI or CT, plain CT? Only plain CT? Okay, that's your mainly tertiary care practice. Other everywhere it is universal. Okay. Okay, essentially, I just thought because I'll be pitching an entirely different, this is a setting from tertiary caps high volume center. So I'll be pitching for something else, which may deviate from your protocol here, which I really understand. So before starting with, I'm a philosophy and history buff. I start with a statement from one of the preeminent Western scholars in the age of enlightenment, Immanuel Kant. He, way back in 18th century, he made a comment that the chemistry and biology of his time are essentially a science, but not the science. Eine Wissenschaft, aber nicht Wissenschaft. Now, essentially, that means that biomedical sciences, they have a practical inability for theoretical prediction. You can't piece together individual piece of information and use the formal reasoning tools like formal logic or mathematics to get an entirely new information, which is the standard of course in exact sciences. Predictably, we have a lot of replication, low replication rate in biological medical. So the phase 2 trials are replicated only 18%. Genetic association studies, only 16% are replicated. And psychology research reports, only 36%. 70% of the reports are entirely non-replicated. So this is a very major issue. So we have a lot of false discovery rates in biomedical science, and this is quite exceedingly high. And for smaller studies, we may say that this is because of publication bias, failure to control bias, hacking, or poor quality studies or low statistical power. And the false discovery rate in biomedical research is so high that the hedge funders, venture capitalists, they say that at least 50% of studies in top journals are non-replicable. So they would like to do a in-house replication before entering into venture capital investment. So John Ioannidis, who's from Stanford, is an authority in meta-research. He, after studying these issues, mentions that false discoveries are quite low in exact sciences communities like many domains of physics, but is exceedingly high in biomedical science. And this, the quote, is it's a science, but not the science. So essentially, biomedical sciences, there's an inability for theoretical prediction. We can't piece to the information based and get entirely new information. So we do RCTs. They are essentially a quasi-scientific tool because we don't have the ability to theoretical prediction. So we just use as a blind devices to see outcome irrespective of the theoretical knowledge of the components of trial. So essentially a tool to mop up lack of knowledge or methodology for theoretical prediction. So essentially a caveat for interpreting RCT is that the outcome of the trials should be born with the design of the study and the nature of the disease. Like you have to have a design outcome complex in your perspective. For a particular design, you have particular outcome and research. So this is essentially relevant to all facts of science. Facts of science essentially are not a facts per se, it's a facts method complex. So that is the demarcation principle which differentiates science from pseudoscience. So you have to have interpretation of studies as a design conclusion complex. But can large multicentric RCTs with independent data monitoring committee give dissimilar discordant results? Like all these issues of hacking, failure to control, low statistical power are all taken care of by large studies, multicentric studies and all. But we have an issue of black box studies. You give some agent to the body, we don't know how exactly it works, and we expect some results. So these black box studies here, we don't really visualize how the agent acts in the body. Like you have an agent X, which is phenotypically defined or mechanistically ill-defined. And so you study on them, and then many times you get restrained or no results in this. We have examples of this in aspirin, statins, HCQ in COVID, like aspirin early studies and all. They even did Chinese stroke, they even do CT scan. And we know the effect size of these studies are highly restrained. The antiplatelet trial is the absolute restrictions of 2%. And we know that 20 to 30% of patients in aspirin do not inhibit platelet. And this causes a large subgroup where the drug is not acting at all. If you look at the trials from statins, when the Lipitor was in patent state, in Jupiter trial, the effect size is a primary prevention for vascular events in healthy individuals. The effect size is 0.59. And Sparkle trial for high dose statins is 0.25 per 5 year. So it's a very low, and even in recently COVID, this study published in Aneesh, was published. They didn't diagnose the COVID based on PCR. They just made a presumptive diagnosis and they got a neutral result. So this is very prevalent. The issues are very prevalent in biomedical sciences, and so much so, John Inundori says that EBM has become more influential. It has been hijacked by different areas, different agendas for which they are aimed for. So, and also there's an unwritten practice in EBM that preceding or established evidence has a privilege over developing evidence, howsoever appealing or dramatic is the latter. So we saw this concept in quite a bit in stroke medicine. But my plan to have a sanity, not to mechanically administer EBM dictates, and give an insight to be an autonomous professionals who can, you can extract the data and apply it in appropriately for our patients in different scenarios. So I'll be outlining the study. I'll be discussing the principles of selection for acute stroke, and then I'll be just discussing the nature of clinical trials and just try to discuss this in the context of evolution of evidence in ESR. So I'll just start with the question: what is a window? What is the concept of therapeutic window? How did it evolve? And what is the basis of the cutoff? Now, we all know this landmark trial, 1995, NINS TPA trial, combat tissue plasminogen for acute ischemic stroke. And you have a laundry list of huge list of inclusion exclusion criteria, and I'm not going to it. It gave included 624 patients, and it gave a favorable modified outcome at 3 months, modified Rankin scale outcome of 3 months of 13%, 13% absolute risk reduction, returning a number need to treat of 8. Now, then the second trial from Europe came, ICAS-3. It gave a favorable outcome at 3 months of absolute benefit of 7.2, and number need to treat of 14. Now, in addition to the inclusion exclusion criteria of NINS TPA, you have, they included only those patients in 18 to 80 years, and they excluded severe stroke as assessed by clinically by NIHS score, and a combination of previous stroke and diabetes. Also, any patient on anticoagulants were excluded, irrespective of PTINR. Now, if you look at the systematic review of IV thrombolysis, this ICAS-3 and NINS TPA were the only 2 trials among a list of 11 trials, in fact, which tried different combinations of the drugs, different windows. And so these 2 trials were positive. So and if you look at the outcome is for the favorable clinical outcome at 3 months. For the death and other issues, it was all neutral. So only the age and alive and independent 3 months, the favorable outcome at 3 months is the positive outcome. For all other things, it's neutral. So if you treat 100 patients, at least 32 patients will be better, and 62 patients won't be in change. The number need to treat about 8 to 40. Now, for the physicians out here, we use a scale called modified Rankin scale, in which 2 or less modified Rankin scale is considered favorable. 2 means light disability, unable to carry previous activity, but able to look after own affairs. Also, we use NINS NIHS stroke scale, which is a stroke severity scale during the acute setting. So anything beyond 8 to 10 is considered a stroke beyond the sphere of small artery stroke. So anything more than 15 is severe disability, mainly cortical stroke. Now, the therapeutic window concept emerged from these 2 trials, NINS TPA and ICAS-3. 3-hour cutoff based on NINS TPA trial, 4.5-hour cutoff from ICAS-3. The older studies on 6-hour cutoff and various other combinations of drugs failed to show results. Now, the issues with the NINS ICAS-3 trial is that they enrolled a broad population of patients. Significant, in fact, we see that significant number of patients between a 3 to 4.5 minutes, you have normal looking CT, at least for those who are not really expert. And many times proximal lesions, which are not amenable to IV thrombolysis, are not picked up. In fact, the proximal lesions, which are middle cerebral artery, IC or basilar, form about 20 to 25% of acute ischemic stroke. And the standard of care investigation, that's per NINS, TPA, and ICAS-3 paradigm, do not predict the outcome of this trial of the patient. And these patients have dramatic disability. And many times, if you intervene this when you thrombolyze a patient, if without reference to the amount of infarct core which has developed, you have hemorrhagic transformation bleeding into the infarct core. So only 25% of the LVOs are lysed by IV agents, and this 25% of LVOs constitute the major mortality and morbidity, 90% mortality and 65% long-term dependence due to ischemic stroke. And the minor stroke, that is without LVO, usually return to function within 6 months. So those patients, the main contributor of ischemic stroke disability in that is LVO. So also the concept of time is brain, when we discuss it in for campaign purpose, this paper by Jeffrey Davis is based on supratentorial acute ischemic stroke, large vessel occlusion. It is not essentially calculated for small artery stroke and local stroke. Those strokes which which generally improve with IV thrombolysis. So we know that these are this early trials was black box studies, where you do without really visualizing what is happening inside the brain. You do clinical trials without vividly demonstrating according what is happening in the body and how the agent is actually supposed to act in the body. So there was 3 trials published in Anedium in March 2013, the IMS3, Mr. Rescue, and Synthesis Expansion. They enrolled among themselves about 1,145 patients. These trials were considered to be trial of final answer, comparing IV TPA standard of medical care with endovascular intervention. They were meant to replicate the pattern of clinical practice at the time. They thought to be pragmatic design because the choice of intervention was at the discretion of the site interventionist. So if you do a meta-analysis of these trials, or you do a meta-analysis of 2014, including all the previous trials, the results is decisively neutral, precisely because these 3 trials, IMS3, Synthesis Expansion, and Mr. Rescue, constituted about 61% of the weight of the whole meta-analysis. So we know that these trials have been wasted. If you invest, if you want to do a one phase 3 trial, it's about 10 to 50 million, about 75 to 37 crores Indian rupee. So there's a lot of implication with this, because many times after the endovascular intervention steeply came down in the West, particularly. Now, why the second generation trial failed to show benefit? This gives an insight into the nature of clinical trials and the whole process of selection of patients for acute stroke revascularization. Also, it gives a glimpse on the regulatory framework and commercial interest, how they skew the logical evolution of clinical trials. Now, in IMS3, if you do look at it, if the synthesis expansion was emerged from another study called synthesis pilot, where they didn't use NIHS cutoff, but they used a less severe stroke, and the patient cohort was treated by IV thrombolysis. This was coming from a negative study. This was synthesis pilot was a positive trial. I'll just come back to slide. So synthesis expansion came from another study which was positive, or going towards the positivity. But synthesis expansion, they want to include new interventional agents. So they combine IVTPA, Mercy, Penumbra, Solitaire, versus IVTPA. So this endovascular intervention, which was relatively established, unestablished, and uncertain against an established agent. So Mr. Rescue also used the same thing, old generation devices. So they followed the inclusion criteria of an TPA ECAS3 trial paradigm. Angiography was not mandatory. ANG was done only after randomization. There was a subgroup of patients who did not undergo study intervention in endovascular group. So we had 23% of patients in IMS3 who were not eligible for endovascular intervention, or the study agent. Now, if you look at the studies before this, the 2013 group of studies, you have these 3 trials, PROACT, PRO3, MELT, which was kind of a synthesis pilot, kind of a positive trials, not clearly positive. And then you have these 3 trials, which are large trials, which were decisively negative. So this positive or near positive early intervention trial was PROACT3, synthesis pilot, and MELT. Now, PROACT2 used what you call as pro-urokinase in angio-proven MCO occlusion with no early signs of symptoms. So it found some benefit for primary outcome of MRS 2 or less. There's about 15% absolute risk reduction. Secondary outcome, however, not positive. Then MELT, there was a trial, very important trial, MELT. This was conducted in Japan when there's a delay in the regulatory clearance for TPA. So they use IA urokinase, but before the study was completed, when the calculated sample, or 20% of calculated sample size achieved, they stopped the trial because by the time TPA got regulatory approval. So because they say that it's because of ethical or scientific consideration, the primary outcome was negative. But if you look at a meta-analysis of PROACT and MELT together, they are positive in favor of the agent, which is IV pro-urokinase. So this is highlights the unwritten practice in EBM, where there's a preceding or established evidence has a privilege over developing evidence, howsoever appealing or dramatic is the latter. Now, in the synthesis pilot, this studied IV EPA with a 3-hour window. The primary outcome was MRS1 at 90 days. Means this MRS1 is not a usually administered outcome measure. Usually there is MRS2 or less. So here the sample size calculated was 300 based on the assumption of 15% difference. Now they also stopped the study when the at least 50% of the calculated sample achieved. And if you look at if you recalculate the study based on MRS2, it was statistically significant with an odds ratio of 4.56, absolute risk reduction of 24%, number into treat of 4. So US FDA wanted 2 overwhelming RCTs or 1 overwhelming RCT or 2 RCT in the same direction to get a approval for the drug. So the company was not ready to do the phase 2 trial, so that went away. So it disappeared from the market. Then came some devices which were like Mercy and Penumbra, which was based on single-arm observational studies, because the devices has a different regulatory requirement in US. So the outcome was recanalization rate. They both achieved a recanalization rate of 60%. So by the time pro-Europeans went to disuse from US market, now for almost 5 years, this Mercy and Penumbra was established as a standard of care. Although there is no standard of care comparing trials, we have single-arm trials based on recanalization rate and surrogate marker of clinical efficacy, because US FDA had a concession for devices over drugs. Then the 2 trials called SIFT and Trevo was initiated. This was comparing a new thrombectomy device called Solitaire and Trevo. Both are stent retrievers against the standard of practice, which is Mercy, for a new non-inferiority design. So these are Mercy against Solitaire. Now in non-inferiority trials, we can have 5 outcomes. You can have one of the basis for doing a non-inferiority trial is that you need to have a comparator which is well established, which compared with the standard of care. Now here in the comparator not well established, there are no RCTs on that, and although this study went ahead, they found that there's a huge difference between the effect size of the new device, which is Solitaire and Trevo, against the older device. So much so, these trials, these studies, these agents were considered to be clearly superior. So if you look at this effect size, if you compare with the older, aspirin 1.1% and statins 2.2%, there's a huge effect size. So these trials demonstrated in sidelines that the new agent is hugely different from the established agent, which were not really established by a standard trials. So in 2013, so what happened is that when these trials in 2013 global trials came up, they were actually piggybacked on relatively successful trial design, where they didn't consider the heterogeneity in the trial design, derailing the logical evolution of trial design. So many years was lost out of this. Then in 2014, Mr. Clean was published. 2014, it compared the newer generation of stent retriever against the standard of care, where the inclusion criteria was included angiography. So once Mr. Clean was published, all the trials which are ongoing, at least 5 of them, did interim analysis and was published within the next 3 months, and all was positive in the same direction. Now, further studies about, I think, more than 4 or 5 studies were published. There's about 9 trials as of now. The common denominator of these trials were they all used, the population was proximal anterior circulation stroke. They all used stent retrievers. Majority of them used stent retrievers. They used some other imaging modality to determine the core. So now I just want to explain this thing. This is a forest plot. So forest plot is called forest because it looks like a forest of plots. Now here you have individual studies, and this is a line of no effect. And if the study confidence interval study touches the line of no effect, it means that there's no difference between the age. And there's the diamond in the bottom shows the final estimate. So if you do this meta-analysis was done in 2014, published in BMJ. They compare 2013 trials and 2015 trials. If you look at that, the subgroup, there's an index called I squared. which gives an index of heterogeneity of the trial. This I-square is 0. While the 2015, this I-square is 0. But if you combine I-square, it's about 69. Now, I-square is essentially a index of heterogeneity of the trials. And if you have a I-square more than 50%, you generally don't do a meta-analysis. Fortunately, this paper from our side, so this is heterogeneity is 0. Generally, you should have a heterogeneity, I-square should be 0. Now, in this trial, although the subgroups had subgroup didn't have any much heterogeneity, the final outcome, huge heterogeneity over 69, and that essentially was the story. You would have a hugely heterogeneous population giving neutral results. So that's an important property of clinical trials. So what made the new trials peculiar? They were homogeneous. They selected patients based on CT or MR angiography before randomization, and almost all used methods to estimate the infarct score, aspect score, MR, TT perfusion, or multiphase angiography for assessing collateral. Also, they brought about the concept of issue window, extended the time window. Now, the concept of infarct score is very important for patient selection. Now, if you don't really select the patient where the infarct score is less, you won't get a good result. So, one of the tools which we found very useful is Alberta stroke program early CT score, aspect score. It is essentially designed for, is validated for MCA. There is posterior aspect score as well, but they're not validated. In MCA territory, they divide into 10 regions. Yeah, so you have this caudate, internal capsule, lenticular nucleus, insula, M1, and so there's a ganglionic. There are two cuts are taken: ganglionic cut and a supraganglionic cut. M1 is anterior MCA, M2, M3, and one cut above this M4, M5, and M6. So this is color coded out here. Now, in the NINS TPA trial program, the exclusion criteria was CT demonstrate multilobular infarct, the hypotensity more than 1/3 of cerebral hemisphere. Now, this is very fussy. Now, you can't really communicate properly. Now, aspects helps better communication of degree of infarct score, especially when the decision has to be conveyed across multiple stakeholders. Now, we found the original study has found that any aspect less than 6 give poor results. Although there are studies showing that there are studies on borderline areas as well, but generally the thing, anything less than 6 give poor results. Anything above 6, outcomes good. Now, in the pivotal trial, they, in addition to the aspect, they use a rapid software, which was an automated AI-based software, which has estimate the perfusion as well as the diffusion, and then calculate the perfusion diffusion mismatch ratio. So this is extend 1A, fifth prime, Revascularization, dawn, and diffuse 3. So if there is a perfusion defect, double the infarct. The ratio is about 1.8, and aspect is less than or better than more or better than 7. It is considered to be very good. So one issue with the doing MRI in the acute setting is that there is a lot of movement artifact, a lot of time is lost, and the Calgary Calgary group has devised something known as multiphase angiography, wherein they just this is the first slice starting from the aorta to the vertex. Then they take 2 other slices that is 4 seconds apart. So the whole scan finished within 8 seconds. Now, so they find that if you use multiphase angiography, you get more patients with for intervention. So, like in this top panel, you have a cutoff out here, but all the arteries are reforming through leptomeningeal collaterals. So these are perfused tissue. If you intervene in this patient, you have very good results. On the second panel, you have a cutoff, but it will be intermediate collaterals. While in the last panel, you have this cutoff of the right MCA. Though there's whole hypodensity out here, you can't see collaterals. So unless you intervene very fast, within 30 minutes, you won't get good results. So there is certain issues with multiphase angiography. It misses out the cervical, a concept called cervical proximal pseudoacclusion, while using 64 slice or above scanner. So in this case, I'll come to back to, because I have certain slides to show, videos to show. I'll come back to this concept. Now, in this case, you have a cutoff, but there's a lot of collaterals of these patients do well if you intervene early. So now the dictum is that this is an important dictum. While the clot in the vessels are the reason why we treat patients, collaterals are the reason why we are able to treat. If you don't have collaterals, you won't be able to treat them, or you have to treat very fast. Now, there are certain group of patients who have good collaterals, and these patients remain in the same state for a prolonged period of time. These are very small subgroup, maybe less than 5%. This Dawn and Diffuse trial was done focusing on these group of patients. So they essentially used two criteria. One is the large vessel, the common denominator was large vessel occlusion with low infarct core. That means aspect more than 7 or more than 10. And this corresponds to a infarct core assessed by CT perfusion or MR perfusion 70 ml, and perfusion defect double the diffusion defect at 1.8. This is in diffuse 3, and in the Dawn trial they used clinical imaging mismatch, low infarct core and high NIHs more than 10 for different age groups. So later on, there are other devices which emerged up, like the aspiration devices, and they are shown to be equally potent. Now, if you summarize all the trials, the effect size ranges from 11 to 25, the number needed to treat from 7 to 3. So if you treat, number needed to treat is about 4. While the IV thrombolysis, the number needed to 8, while in thrombectomy, number is about 4. And in certain scenarios, in clinical scenarios, it may be as good as 1.5 to 2. Clearly, one of the most effective treatment in medicine. Now, one of the caveats you need to hear is that you want to apply a thoughtful selection protocol and maintain a very rigorous work standards comparable to the work standards which was demonstrated in the pivotal trials. If you don't establish that work standard, you don't get the results. You have to intervene within 45 minutes. That's 30 minutes is ideal thing. Otherwise, within 45 minutes, if you don't intervene and you reanalyze, you won't get the results. So there's no point. If you do a scan and do the intervention after 2 hours, you won't get the results. You have to maintain the workflow. That's a very, very important thing to get the good results. So you have to maintain this workflow unless you don't get it. So the bottom line is that what I can explain as deep selection, which is really miles away from TPA trial paradigm. Here, time is an important factor. I emphasize again and again. And outcome is a function of rapidity of recanalization. Now, there are other 2 trials as well, which extrapolated this extended thrombolysis in IV thrombolysis group. This is wake-up trial, which used MR-guided thrombolysis for stroke with unknown time of onset. They randomly assign patients using a protocol called diffusion weight, diffusion flare mismatch, where you have a signal in diffusion abnormality, but there is no flare abnormality. This indicated that stroke had occurred approximately within previous 4.5 hours. The trial unfortunately was stopped because they couldn't get funding because it's a very slow recruitment after 503 patients, and they compared 255 patients in the control against 249 in the control. So the outcome was the absolute risk of increase in the favorable outcome of 11.5 and number needed to of 9. The secondary outcome were all neutral. Now, so this is a patient. So this patient came with an NIHs of about 15. So you have infarcts out here in cerebellum, but brainstem is completely clean. You have a top of viscera. So this patient is a very good candidate for intervention. So there's a diffusion flare mismatch. Now there's another trial in the same genre, extent trial, which enrolled patient up to 9 hours, where they used the diffusion perfusion mismatch, perfusion, CT perfusion, automated perfusion imaging. So this study again was terminated because I'll just come with it. So, so this study actually was stopped because the DCMP thought that after the publication of the wake-up trial, there is a loss of equipoise on the publication, so they have to terminate. But when they did the analysis, the primary outcome was positive, 5.9%, very low, NNT of 17, secondary outcome were all neutral. And they concluded that the use of alteplase therapy in patients with a favorable perfusion imaging profile within 4.59 hours show minor benefit, but because of the limited power of the conclusion as a result of premature termination of the trial, and the lack of significant difference between the group in secondary outcome, further trials need to be done in this area. So that trials, the cost of the trial will be about $350 million. Now, so that is, so if you summarize the whole evidence, in a patient coming within 3 hours, if there's a large vessel occlusion and the aspect is favorable, we can to do a bridging IV thrombolysis followed by thrombectomy. This is for proximal MCA and distal ICA. For distal MCA, the number of patients in the trials were not very high, so it is considered to be thrombectomy is reasonable. While in India, the tentative is approved for 3-hour window, and the dose is 0.25 mg per kg body weight. And for the patient coming within 3 to 4.5 hours, proximal is the same process. While there's no approval for using tentative in India for 3 to 4.5 hour window. For those patients who are between beyond 4.5, 6 hours, there is no bridging thrombolysis approval. While those patients beyond 6 hours, we have to do, and there is a large vessel occlusion, we have to do with the protocol of diffuse 3 or DAWN. That we have to do a MR or CT perfusion and look at the perfusion mismatch ratio, a ratio double 1.8. So now there are certain border zone issues in the evidence, like posterior circulation stroke. Now, posterior circulation stroke, you don't have trials because it's very difficult to do as trials because the onset may not be clear. They'll have stuttering course, the thrombus may progress, you have deficits alternating, fleeting deficits, TIAs. So when is the onset, we don't know. But what the protocol generally adopted by most people are MR-based protocol. So what we do is that if you have a patient who is have a severe deficit, what the MR is not showing significant deficit, significant. Can I continue? Can I continue?
Yeah, I think how many slides?
So
Summarize and.
So essentially, if you have a whole brainstem gone and there's a top of vessel environment, we don't intervene. There's no point in intervene. But the relatively minor infarct, like the one which I showed here, and there is a basilar in top involvement, basilar involvement, or mid basilar involvement, we have to take it out because this may progress. So the patient with large vessel occlusion with low NIHS score is a dilemma because these patients are all precarious. They have a cutoff. There's a good collaterals hanging on. When they worsen, we don't know. So sometimes we discuss with the patient relative and decide based on their, because we had many issues when we keep this patient, they suddenly collapse and suddenly worsen up, and the late-night thrombectomy and all may not be successful. So there's no clear evidence here. So what we do in NIMHANS, we have a protocol which is established and a green channel. This is all priorly discussed, and any patient. So we decide based on the onset NIHS score, plain CT aspect, CT angio and CT angio source imaging aspect. I have two slides. Can I show that because this is a very important slide? This will take 5 minutes more. So I
think you better show your summary slides and 2-3 slides.
Okay.
Because already we are 3-4 minutes.
Yeah. So patients beyond 6 hours with LVO, we generally use MR-based protocol, diffusion with perfusion mismatch. All patients posterior circulation show undergo MR-based protocol. IV thrombolysis beyond 4.5 hours depends on how plain CT scan is looking. If aspect is full and there is no LVO, we thrombolyze without MRI. Now I have few cases to show if their time allows. If aspect is not clear and there is an MR, you do a flare and diffusion or ASL perfusion and contrast perfusion. So I will show a few images. So now this is fairly straightforward. So what would be the aspect? Any physicians? The whole MCA is gone. This aspect is 0. So you have best score is 10. When you have CA hypertensity or hypertension, you deduce that. So the whole MCA is gone. Right side. So there's nothing. And this page, what was this aspect here? Neurologist. So this was the same patient few hours back. the whole MCA is hypertensive. But there is a pity because there are a lot of inter-observed variability in aspect. There's one major issue with aspect scoring. Now here comes what is known as CT source imaging. Now this is another patient. The aspect anyone can guess. First image, right side, left side. So that there is a lot of debate. So the acute setting, the radiologist told that, oh, this is poor, we can't do. Then we had a very good faith in this CT source image. Now I don't have a corresponding cut, but I thought that this was good aspect. There is no infra development. Then we did. So radiologist went ahead and doing the MR. This was this, and this we went ahead and we had a good result. So essentially, if you look at it, CT plain image aspect is very poor. A lot of inter-observed variability. And if the fact that there's inter-observed variability means that's a good scan. Means, and if you had to do a CT image source image, that left collateral, that will be a good idea. So now this is an important video. So
I think Dr. Srijithesh,
okay,
please show
I'll
your
stop it.
summary slides.
I'll sum it.
So
So
we can proceed to the next presentation. And Madan, are we taking questions right now or after the 3? So we are not taking any questions. So please show your summary
Okay, I'll
slides.
summarize it. So essentially, the time-based window is long being observed. You have to base increasingly on imaging. Especially, I would suggest you also look into CT-based source imaging. Now, the data from RCTs are probabilistic inferences of group means. Applying them to rigid standards, we had few cases I could unfortunately show that rigid manner in individual cases is not scientifically correct. You always has to look at this intersection. This is the rings of EBM. So evidence-based medicine, the real practice is built here. You need to consider patients' preferences, research evidence, as well as clinical situations. You have different diverse situations. So we have to increasingly base our judgment on radiological picture and clinical effect, and each center has to adapt guidelines of acute stroke intervention to its own system. Now, I would say that CTA is sine qua non of modern acute stroke imaging because it is virtually a glass house through which you can simultaneously see the brain and its vessels, and it has the best possible trade-off needed for acute stroke imaging. So these thoughts have been summarized in this article published in AN. Okay. Thank you. This is Enhanced Super 94. And thank you.
Thank you, PR Srijithesh sir, for a nice talk. Now I would request Dr. Neeraj Bhutani sir, Dr. Gaurav Goyal sir to present a memento to PR Srijithesh. Thank you, sir. Thank you, sir.